David. Good afternoon, and thank you for the opportunity to provide a brief statement on behalf of the American Osteopathic Association. My name is Susan Friedman. I'm Deputy Director of Government Relations for the American Osteopathic Association. The AOA represents more than 100,000 osteopathic physicians and osteopathic medical students. We commend the Institute of Medicine for undertaking a new and comprehensive look at the current state of end-of-life care. We believe that there needs to be an ongoing dialogue among health professionals, patients, and caregivers regarding the multidimensional nature of this important issue. Over the years, the AOA has been a reliable source of information in educating DOs and patients about end-of-life care issues. Since 2001, the AOA Council on Palliative Care Issues has developed osteopathic education in palliative and end-of-life care modules, including a module on cultural competency and end-of-life care. We've developed a conjoint examination for a certificate of added qualifications in hospice and palliative care, first administered in 2009. The conjoint board includes members from the boards of internal medicine, family practice, physical medicine, rehabilitation, neurology, and psychiatry. We've provided continuing medical education programming for the annual AOA Osteopathic Medical Education Conference, including programs on diagnosis and assessment of terminally ill patients, pediatric hospice care, and assessment management of pain and non-pain symptoms. We've provided clinical expertise to the Collaborative for REMS Education, and we will provide a CME program again at our 2013 conference and at regional programs. We've also drafted a policy statement that was adopted by our House of Delegates on end-of-life care, and it's available on the AOA's website. Again, thank you for the opportunity to speak, and please call on the AOA if we can help you with your committee's deliberations. Thank you.
Thank you, Susan. And let me apologize in advance if I don't pronounce somebody's name correctly. Dr. Mukwanye, who's the Director of Center for Ethics at the Washington Hospital Center. Are you by yourself, or do you have?
Yeah, Dr. Dorenzo.
Dr. Dorenzo, who's the Senior Clinical Ethicist, Center for Ethics at the Washington Hospital Center, is also here. Please, Doctor, proceed. I apologize if I didn't
No,
get
did a very good job, actually.
Well,
thank you
very much.
Good afternoon, everyone. My name is Naka Mukunye. I'm the Director of the Center for Ethics at MedStar Washington Hospital Center. And I wanted to come, along with my colleague, Dr. Dorenzo, to express our side of the picture for end-of-life care. There's not many hospitals around that actually have clinical ethicists on staff that do clinical ethics work. And so this is a big passion of ours. We run roughly 300 to 400 consults a year, and the majority of them are around end-of-life care. We do sort of specialize and train towards end-of-life and in the ICUs, and Dr. Dorenzo, I know, will talk a little bit more about that. But what I wanted to discuss with the committee especially is our belief that the best way to provide good end-of-life care is around doing things early and upstream, right? So preventative ethics is sort of the motto that we use to train at the Center for Ethics. We train our residents to it. Our physicians are trained the same way. We were set up by Dr. John Lynch in 1981, who some of you may know is a very famous oncologist in the area, who started the center because he wanted his patients to die better. And that was part of his understanding, which is how we framed the way we do practice at the clinical ethics department there. So upstream in preventative ethics means that you take the time to initiate the diagnosing of dying early, to give people the opportunity to understand what is coming down the path. I think that one of the things that needs to be addressed is this belief that physicians seem to carry that dying means they've failed. If their patients die, then there's some sort of failure attached to it. We try and help our physicians to believe that no, that there is the element of trying to cure, but when that is not possible, you have to transition now to being the agent of caring and comfort, and that is not a failure. So having to address this death as a failure concept, I think, is one of the number one issues that needs to be, we need to deal with. Because if we have that done, then conversations around advanced care planning, I think, will be easier. Conversations initiated early with diagnoses that we all know are terminal, including life being terminal, but some that are a little more terminal than others would be easier to have as well. And also, it would be better in a clinical setting to have patients who come in already aware of what their steps are going to be, already aware of the trajectory of what's going on, so they can stop things earlier. Doing this, I think, gets at the mission of what this committee does. Decreasing the cost of non-beneficial end-of-life therapies would be paramount. Doing this would address that, improving the quality of life of the patients at the end of their life, as well as improving the compassion of care that the healthcare teams can give. So, thank you, and I will turn it over to Dr. Dorenzo.
Thank you, NECA. Mr. Walker, Phil, wherever you are, it's nice to know you're out there. Members of the committee, I'm Evan Dorenzo. I am the Senior Clinical Ethicist at MedStar Washington Hospital Center, and I'm the editor-in-chief of the Journal of Hospital Ethics, and so we focus most heavily on patients in the hospital setting. Washington Hospital Center is a 900-plus tertiary care facility here in the district, and that means that we have a lot of deaths. Our residents have to deal with a lot of deaths. Our staff has to deal with a lot of deaths, and so that's a lot of what we do. So I'm going to focus my comments on trying to think about the transformation. And when one thinks about how medicine is practiced, excellence in medical treatment ordinarily requires that a diagnosis be made. There are criteria, many, including many lab values, for dead. There are none for dying. And so it's very difficult to have a conversation about whether I, as a patient, or my family member is dying with a physician who is unable to make a diagnosis. It just doesn't work. Nobody wants to be dead. Nobody wants to get dead. Nobody wants their patients to get dead. So there is a natural disinclination to have these conversations. There are all dozens and dozens of psychological barriers. I'm sure you'll go through those. So we have begun to work on trying to figure out how to help our physicians make the diagnosis of dying, because that's what assures good treatment. There is, in the literature, a clinical method for assessing whether a patient is dying. It is the surprise question. I will leave it to you in the committee to do that research. But when that question is answered by a physician and his or her physician and nurse and social work colleagues about a patient, about whether you think this patient in a certain amount of time will be dead of their disease or could be dead of their disease, that's the time the diagnosis that we teach, that the diagnosis of dying is made. Medicare assesses it that way. Hospice assesses it that way. And so once the diagnosis is made, then good end-of-life care can be provided as treatment, and what good end-of-life care looks like is well articulated. That is clear, and everybody knows it now. And it is the standard of practice. So when you talk to physicians about practicing within their standards of practice, I know I'll be out in a second. Legally, they have to practice within their standards of practice. We know what those are. So once the diagnosis is made, we know what the standard of practice ought to be, and that's where it starts. I will conclude by saying making the diagnosis is what helps patients and families start the psychological transformation to what does it look for me or my family member to die well. And it is all of our responsibilities to assist. But when we say to families, we're not doing this, we're not doing that, we begin to reduce the trust because we get into an oppositional relationship with our patients. But if we say, this is the diagnosis and this is what we're going to do, then the trust builds and the patient-physician communication and dyad that is so critical is strengthened, and the whole situation works. And so I would invite the members of the committee to come hang with us at Washington Hospital Center, see how we do it, see how our physicians are trained, and then if the committee can provide any help in formalizing that kind of training model, we will be very grateful. Thank you.
Thank you very much. William Benson, Principal Health Benefits, ABCs, and International Association for Indigenous Aging. Is William here? No, he's not here. All right. Mickey McIntyre, Chief Program Officer, Compassion and Choices. Mickey.
Great, thank you very much. As he just said, I'm Mickey McIntyre. I'm the Chief Program Officer for Compassion and Choices, which is a national nonprofit consumer organization dedicated to improving care and expanding choice at the end of life. I appreciate the opportunity to speak with you all today. Compassion and Choices' central tenet is that as Americans, we are free to choose how we live. And so it follows that when the time comes, we are free to also choose how we die. This private, personal decision among all Americans and their families should occur free from government interference. Today, I want to urge the committee to address unwanted medical treatment at the end of life. Patients have the right and responsibility to guide their own health care throughout their lives, not just at the end of life, in consultation with their trusted health care professionals. Many Americans give thoughtful consideration to medical decisions that may need to be made if they are injured or debilitated, and they articulate their decisions in advance directives. Nevertheless, many patients' decisions are overridden or ignored in the weeks and months before their deaths. This happens for a variety of reasons, some of which were already mentioned, and can lead to invasive and fruitless testing, needless suffering, unrelenting pain, and prolonged periods prior to death. Patients are tethered to monitors and to machines despite their determination to reject unwanted treatment and desire to die at home in the embrace of their loved ones. Dr. Tino's new study, which was published in JAMA, found that between 2000 and 2009, treatment in intensive care units in the last month of life increased from 24 to 29%. The accompanying editorial concluded, the focus appears to be on providing curative care in the acute hospital, regardless of likelihood of benefit or preferences of the patient. If programs aimed at reducing unnecessary care are to be successful, patients' goals of care must be elicited and treatment options such as palliative and hospice care offered earlier in the process than is the current norm. Compassion and Choices could not agree more. We should provide both a carrot and a stick to ensure that patients' wishes are honored. Financial incentives for honoring advance directives and financial disincentives for disregarding patients' expressed wishes. The Centers for Medicare and Medicaid Services should deny payment to providers where there is clear evidence that specific treatments were unwanted, similar to policies where unnecessary treatment is provided. The Justice Department is investigating and taking legal action against hospitals and doctors groups where instances of unnecessary treatment are exposed. The same due diligence should be trained on unwanted medical treatment. It is always unnecessary and should be considered a never event. The explosion of the aging population, coupled with our moral and financial commitment to providing health care, unwanted treatment should be urgently provided, an urgent priority for this committee. More specifically, Compassion and Choices believes that initiate and improve the quality of conversations among healthcare professionals, patients, and their families, reimbursing medical providers for participation in advanced care planning with patients and their families well in advance of the illness or before facing end-of-life issues, providing financial incentives and training to encourage medical professionals to offer all of the information and counseling necessary for decision-making, and to ensure the full range of medical care treatment decisions, including curative, palliative, and medical assistance in dying, are freely available to patients without institutional and reimbursement barriers. We have other specific recommendations for CMS to engage in trying to disincentivize the provision of unwanted treatment, which we would be happy to discuss with the committee at an appropriate venue and time. Thank you so much.
Thank you. Rosalind Kipping, President, Compassionate Choices National Capital Area Chapter. She not here? Okay. She is? Oh, thank you. So I apologize. We haven't met before.
I was asking Adrian to distribute some material. My name is Rosalind Kipping. I am president of the National Capital Area Chapter of Compassion and Choices, which comprises Washington, D.C., Maryland, and Virginia. Compassion and Choices is committed to improving the quality of care and increasing choice for terminally ill, mentally competent adults. To this end, we support physician aid in dying, an option available to residents of Oregon, Washington, and Montana. You have my written testimony, to which I add the following comments. Those who request physician aid in dying are not suicidal. These individuals want to live, however, their bodies are dying, and they want to be in control of when, where, and how that death will occur. Well established in the practice of medicine and in law is the principle of bodily integrity. The individual has the right to refuse any and all medical treatments and to remove any life-prolonging interventions. The individual has the right to receive high doses of pain-relieving medication with the full knowledge that such a high dose may hasten death. For severe and unremitting pain, the individual has the right to receive terminal sedation, a process whereby that individual is placed into a drug-induced coma, after which further life support is withheld or withdrawn. From the patient's perspective, is the decision to no longer receive dialysis, withdraw a feeding tube, turn off a respirator, or submit to terminal sedation any different than the decision to choose to hasten death by consuming drugs prescribed for this purpose? And so I now ask each of you, which of the following options would you choose if you were suffering and terminally ill with only 6 months to live? Forego all food and water with the intent to die, recognizing that the process may take as long as 10 days to 2 weeks. Agree to terminal sedation. Death is inevitable, but may take 10 days to 2 weeks. Do nothing and continue to have periods of severe, unrelenting, and intolerable physical discomfort or pain without the prospect of significant improvement until the very moment of death. Ingest a legal dose of a life-ending medication prescribed by a physician, as is practiced in Oregon, Washington, and Montana. This results in a peaceful death in about 5 minutes. In closing, I leave you with the thought that the choice of aid in dying is the self-affirming decision of a person who is dying and can only choose the manner of an imminent death. Thank you.
Thank you. Lisa Culver, Senior Specialist, Clinical Practice, the American Physical Therapy Association.
Thank you for this opportunity. I would like to correct my credentials. I do have an MBA, but DPT would be more appropriate. I have a doctorate in physical therapy, and I'm here representing the profession of physical therapy. In 2008, the Medicare and Medicaid conditions of participation for hospice and palliative care mandated that physical therapy services be made available and provided by licensed physical therapists in a manner consistent with accepted standards of practice. Although physical therapists have been involved in the provision of hospice services in a consultative basis and to a broader population for considerably longer, the establishment of the Medicare mandate has mobilized extensive efforts within the APTA to identify specific outcomes related to our interventions in both hospice and palliative care. In the past several years, physical therapy members of APTA have published research demonstrating improved quality of life through improved function, energy conservation, relief of breathlessness, fall prevention, skin protection, and pain reduction in patients facing end of life. I do have some formal comments that I can provide to the appropriate person that has a bibliography attached. APTA members have also developed and published a model of care for physical therapy and hospice, including rehabilitation in reverse, which prepares patients and families for safe and optimal function in the face of progressive decline. Notwithstanding the success of these initiatives, many healthcare providers lack awareness of the benefits of physical therapy services for end-of-life care, which limits access to patients whose quality of life could be otherwise enhanced. One of the 7 core values of APTA is social responsibility, which involves optimizing the value and availability of physical therapy interventions for a changing demographic landscape. For example, it's expected that a demand for physical therapy services for quality at the end of life will increase significantly with the aging of the baby boomer generation, as was mentioned previously. Thus, APTA is committed to the participation in interprofessional initiatives to seek and improve end-of-life quality of care. I'm going to do just a couple of really quick scenarios and then let you know that as an organization and as a profession, we would love the opportunity to participate through field review, participation directly with the committee in whatever way we can. But a couple of scenarios. One is a 60-year-old female with metastatic cervical cancer and severe bilateral lower extremity lymphedema. She was able to ambulate with a walker in her home following manual lymphatic drainage and the application of compressive dressings. And a 12-year-old girl with Charcot-Marie tooth disease developed a glioblastoma and used a wheelchair following surgical resection, radiation, and experimental chemotherapy. Over 6 months of home palliative care and and physical therapy, they enabled her to gain sufficient strength and function to return to school for her sixth grade graduation, ambulating with bilateral AFOs and lost-strand crutches. And then with her family, she enjoyed a Make-A-Wish visit to the Philippines. After subsequent tumor recurrence, she received hospice physical therapy services for the family, training in independent transfers, and bed care. Thank you very much.
Thank you very much. Dr. Joan Harold, Medical Director and Vice President of Medical Services, Hospice and Community Care. Thank you. And again, if you're scheduled to speak soon, please move up front. Thank you.
On behalf of many of my hospice colleagues and at the invitation of the National Hospice and Palliative Care Organization, thank you for allowing me to make comments. Since the Institute of Medicine published the groundbreaking work Approaching Death, Improving Care of the End of Life in 1997, progress has been made. Hospices across the country have helped promote that progress, and we hope that this committee will see hospice as a valuable resource and partner in the continuing transformation of end-of-life care. Research confirms that 8 out of 10 Americans want to remain at home for the end of their lives. Hospices have helped this happen for more people of all ages and diagnoses. In 1984, hospices cared for about 100,000 people. In 1996, about 450,000. And in 2011, more than 1.5 million people received hospice care, almost 45% of the deaths in this country. Hospices are innovators in healthcare. Hospice started as a grassroots alternative for end-of-life care at home, and cancer was the most common diagnosis. Now, more than 60% of hospice patients receive care during the end stages of Alzheimer's and other dementias, heart disease, lung disease, kidney disease, liver disease, and frailty of old age. What began as a community-driven movement to improve the way people die is now an integral part of our healthcare landscape. But even as hospices have adapted to meet the various needs of more people, we have remained steadfast and committed to our core principles. Center care around patients and families. Help patients define goals based on individual values and preferences. Provide interdisciplinary, holistic care for medical, emotional, and spiritual well-being. Support caregivers during the course of care and during bereavement, and maintain a steadfast commitment to relieve pain and suffering. This care is comprehensive and can be complex, yet research has shown that Medicare saves $2,200 for every beneficiary that uses hospice care. This is not because hospice hastens death through an absence of care. Instead, study has actually shown that Medicare patients with some of the most common cancers live on average almost a month longer than similar patients who do not receive hospice care. Earlier access to palliative care services can prevent ICU admissions, emergency room visits, and repeated hospitalizations. Hospices are successfully integrating palliative care services into accountable care organizations, PACE programs, and healthcare systems in Michigan, Florida, Pennsylvania, Kentucky, North Carolina, New York, California, Kansas. I'm sure I've left some of you out, and other places as well. Moreover, hospices are known and trusted in their communities. We must continue to leverage the services, skills, compassion, and reputation of hospices to provide people with effective palliative care earlier in the course of serious illnesses. Those of us who work for, volunteer with, and have experienced hospice care hope that you will seek to build better care upon this network of hospice programs. For more than 30 years, hospice has improved care for the seriously ill and dying. We look forward to continuing that commitment with you. Thank you.
Thank you. Kristen Santiago, Manager, Strategic Initiatives, Sea Change.
Good afternoon. I'm Kristen Santiago, and I am here today on behalf of Sea Change. We are a national cancer collaborative made up of leaders from major private, not-for-profit, and public organizations devoted to reducing the burden of cancer. We would like to thank the IOM and this committee for your important contributions, and we note your 1997 report, which has been an excellent roadmap. As part of Sea Change's collaborative efforts, we have incorporated some of your recommendations into our work to increase the use of palliative care throughout cancer treatment, to increase the number of individuals accessing hospice care, and to increase the length of hospice care. We have known for a long time that pain control is an important part of caring for cancer patients. Yet currently, 40% of cancer survivors and 60 to 85% of people with advanced cancer are still living in pain. We would argue that people with cancer are harmed when they are not active partners in their treatment decisions and when their options and realistic treatment benefits are not openly discussed when these decisions are being made. Currently, fewer than 40% of patients with advanced cancer have realistic conversations with their providers about treatment options and alternatives. 65% of medical oncologists wait until there are no more non-palliative options before they bring up hospice as an option. However, some important strides are being made in this area. A number of professional groups, such as ASCO, have stepped forward to make some changes. Your 1997 report notes that medical culture tolerates and rewards the misapplication of life-sustaining technologies while slighting the prevention and relief of suffering. This rescue mentality and our inability to have more timely, direct, and honest conversations results in 16 to 20% of individuals with cancer receiving chemotherapy within 14 days of death. This is when the impact on the quality of life likely outweighs any potential benefit. The 97 report addressed the struggles that our nation has in speaking realistically and comfortably about the end of life. Sea Change has recently conducted focus groups with hospice volunteers, and some of the comments that were made were illuminating and framed things in a beautiful and telling way. One retired nurse who volunteers at an inpatient hospice stated that there is a myth that hospice is where you go to die, but in fact, you go there to celebrate life. This statement was made by a woman who has seen many loved ones pass away from cancer and who has decided to pay it forward and volunteer in a hospice. If we can keep this type of sentiment in our minds, we can begin to tell a different story, one about the quality of how one lives and less about unrealistic expectations of immortality and a healthcare system that is expected to save everyone. To progress and improve the quality of care for persons with serious illness, we must accomplish 4 key goals. First, we must develop a robust research agenda that addresses and reflects the views of populations with health disparities. Second, we need to define and implement a supportive payment structure. Third, we must address the quantity and competency of the workforce. And finally, we need to engage in an extensive campaign to ensure that all Americans know what palliative care is and know to request it at the time of diagnosis of a serious illness and not in the days before death. Similarly, the benefits of hospice need to be better understood by the public and by practicing clinicians. In closing, I would once again like to thank the IOM for taking up this issue. No one group or sector or organization alone will be able to solve this. This is a foundational societal and cultural change process. And once again, if we increase the use of palliative care throughout treatment, increase the number of patients and families accessing hospice care, and increase the length of hospice care, we will ultimately improve the quality of care for those who need it when they need it most. Thank you. And I have copies for the committee.
Thank you.
Thanks.
Dr. David Lognecker, Director, Association of American Medical Colleges.
Thank you. And our compliments to this committee and the actions of the IOM. This is really important work, and we are with you 100% along the way. I've submitted my comments in writing, and I'm simply going to abbreviate them a bit here in the interest of time. For those of you not aware, the AAMC represents 141 accredited allopathic medical schools in the U.S. and 17 in Canada, and collectively about 400 teaching hospitals, and the faculties and students and residents that are part of those organizations. I would like to say that AAMC really is particularly interested in this for 2 reasons. First and foremost is simply the fact that the AAMC mission, one of the key aspect of it is improving the health of all, and that is exactly where this area falls. Secondly, though, there are 89 ACGME-approved hospice and palliative care fellowships. 83 of those are sponsored by AAMC member institutions. So we have a very strong commitment to that educational role. I'd like to make 5 quick points and then offer a personal comment. Number 1, that high-quality, coordinated, person-centered care really is an obligation as well as a right for all Americans. We need to focus not just on a few specialties. We often focus on oncology, palliative care, cardiology. This must become pervasive across all medical disciplines and all healthcare provider disciplines as well. Secondly, that widespread educational efforts are needed for the public and for providers, both. And I could go into some detail, but suffice it to say that the Regents Foundation survey that was done a year or 2 ago pointed out that particularly older providers are simply less aware of the benefits of what can be done with palliative care. Younger ones more so. More work for all, of course, is needed, and the public is very confused about such issues as palliative care. Third, I would just point out that this is truly a team effort. It goes well beyond the doctor-nurse relationship in caring for patients and extends to a wide variety of providers, all the way across the various care disciplines and into, for example, community health workers as well. Fourth, AAMC has been working in many areas to try to foster these activities in terms of education, but needs your help, and we welcome it, and will not in any sense resist it should you come up with suggestions that you think we could have done better. We think we could always do better, and we want to hear your thoughts on it. Finally, I just, in terms of policy, I would just point out that no one has mentioned that there are policies that need to be changed for this to work effectively, and none of us have mentioned it so far. I'd encourage you, and I know you will consider it. Finally, just one personal comment, if I might. This is my own observation, but I think terminology is outmoded and is contributing to some of the problems that we have with the delivery of palliative care, end-of-life care, advanced care planning, etc. We already know that the studies show that palliative care and hospice care are delivered far too late in the process. And I would submit to you that the continued, and we've used it all day today so far, the continued focus on end of life contributes to that. And I would suggest to you that there are circumstances, for example, my own particular area of interest happens to be in heart failure services, but I would just suggest to you that the time when palliative care, advanced care planning, et cetera, should be implemented in patients who have a diagnosis of heart failure is at the time of the diagnosis, not downstream. And I urge you to think about the language that we use, see if we can get a more standard language, one that's clearly understandable by the public, and hopefully as a result of that, add to the solutions to these issues rather than contribute to the obfuscation that for some is apparent. So thank you very much.
Thank you, Doctor. And let me note for the record that we're looking for language. We fully much recognize that words matter, and this is a very difficult topic. Sally Welsh, CEO, Hospice and Palliative Nurses Association.
Good afternoon. The Hospice and Palliative Nurses Association represents over 11,000 nurses and other members of the interdisciplinary team, including social workers, chaplains, nursing assistants. We have chapters in 50 states across the nation. The mission of HIPNA is to lead the way to promote excellence in the provision of palliative nursing care through leadership development, education, and supportive research in the field. We are also part of the Alliance for Excellence in Hospice and Palliative Nursing, which includes the National Board for Certification of Hospice and Palliative Nurses. So we do a lot of education and training and making sure that the providers in our field are quality providers. We appreciate the previous work done by the IOM committee, and we also appreciate the IOM Future of Nursing report, and we're very pleased to see nursing included on this panel. As to the specific work of this committee, we see the following issues as priorities. First of all, patients should have access to the most appropriate, effective medication for pain and symptom management. Quality of life is extremely important and the main issue. Patient care and treatment should be based on individual needs. We encourage a balanced approach to prevent misuse of pain medications while preserving access for patients who desperately need this comfort. Secondly, we believe that patient choice for seriously and progressively ill patients is essential, echoing what has been said by many individuals here today early on in the care, and again, the language is extremely important. We also believe that care must be patient-centered and include the expertise of all the members of the healthcare team to provide the quality and care that the patients need. Secondly, we believe that nurses play a vital role in the delivery of healthcare in our nation. Hospice and palliative nurses have expertise in pain and symptom management, communication skills, and coordination of care. Advanced practice registered nurses represent a valuable resource in national efforts to improve care and quality of life for all Americans and their families. Nurses should be, as per the IOM report, nurses should be able to practice to the full extent of their training and education and should be full partners with physicians and other health professionals in redesigning healthcare. On a personal note, my original background was oncology, and then I transitioned into hospice, and that's what drew me into it, was the team model. Developed in hospice, has been transmitted over to palliative care. So I think it does take all of us working together to do what we need to do. Thank you.
Thank you very much. Dr. Marie Delville Mahoney, physician, Cannon Hospice and North Shore Hospitalis. Okay. Dr. Molly Gurian.
My name is Molly Gurian, and I recently completed both my law degree and my master's in public health degree at the University of Minnesota. I'm here today as an interested citizen and someone who's done extensive research in the area of hospice care, so I'm here to offer some comments based on my master's project for my public health degree, which was entitled Rationing Compassion, the Long and Still Not Completed Road to a Properly Robust Medicare Hospice Benefit. I consulted the Institute of Medicine's 1997 report extensively in my thesis and felt today represented one of the best possible opportunities to share some of my findings. The Medicare hospice benefit was passed by Congress in 1982 on, I argue, the strength of two motivations: the desire to improve the quality of end-of-life care and the desire to reduce the amount of Medicare spending that has been resulting from terminally ill patients receiving conventional care. At the outset and over the next 30 years, these motivations have remained in tension, with the result that some of the original cost-saving mechanisms built into the law, like defining eligible Medicare hospice beneficiaries to be only those terminally ill patients who had a life expectancy of 6 months or less, setting hospice reimbursement rates at low level and capping the overall reimbursement that a hospice could receive, and precluding Medicare hospice benefit recipients from receiving curative care, have continued to have a negative impact on the availability of the benefit to all who need it. The history of the Medicare hospice benefits and amendments thereto, along with the research literature on the Medicare hospice benefit, demonstrate clearly that the legislative and regulatory action necessary to enhance the effectiveness and availability of the Medicare hospice benefit lagged significantly behind what was known to be the most helpful for patients and the hospices that serve them, and many of you work on such projects and are probably aware of that. Despite these limitations, the United States, I feel, is much closer to an adequate Medicare hospice benefit today than it was in 1982. The main point that I want to emphasize to the committee today is that while costs have to be considered in today's political climate, hospice care and the impact of the Medicare hospice benefit desperately need to be examined without the inhibition of a cost savings analysis. In order to successfully implement and evaluate changes to the Medicare hospice benefit, costs must be eventually considered, but I hope the committee is able to examine what type of benefit would improve the quality of hospice care the most prior to doing a cost-benefit analysis of its plausibility. The main aspects of the hospice benefit that I found to be in need of a re-examination or improvement were the 6-month rule. As many people have mentioned today, the earlier people are able to access palliative and hospice care, the better, and as the benefit stands currently, somebody has to be diagnosed as terminally, only having 6 months to live in order to gain access to Medicare hospice benefits, and I think that that is due for a change. The curative palliative care divide. The requirement that Medicare beneficiaries give up access to curative care related to their disease remains a huge barrier to accessing hospice care. One author calls this the anti-therapeutic gap caused by the Medicare hospice benefit, and this gap is between the type of care that most dying patients can access and the type of care that would serve their needs. There is a consensus in the literature that the Medicare hospice benefits paradigm of death as a well-defined event should shift to one in which death is recognized as a process during which mixed management, i.e. both palliative and curative care, are appropriate. Programs that look into bridging this divide would also address the issues with the 6-month rule. And as I mentioned, many of you have been involved in some of those programs, and I hope your findings are helpful in trying to improve hospice care under Medicare. Finally, MedPAC and other bodies have examined different mechanisms by which Medicare payments to hospice could be better aligned with the goals of quality care for patients. I hope the committee will look into the U-shaped and other payment options that would benefit hospice beneficiaries and allow hospices to function more smoothly. Obviously, the committee is not a legislative body and cannot directly make changes to the Medicare hospice benefit. However, I know the administration and the Congress will take the findings of this committee seriously, and this study provides an excellent opportunity to voice ideas for change to the Medicare hospice benefit. Furthermore, the Secretary of HHS has the authority under the ACA to institute a concurrent care demonstration project and to make changes to the Medicare hospice benefits payment system. While both of these projects must be undertaken in a budget-neutral way by law, I hope the committee will imagine how an ideal Medicare hospice benefit would look and provide quality hospice care prior to trying to figure out how to make these changes budget-neutral or cost-saving. Thank you very much, and I've submitted a copy of my thesis to the record with proper citations.
Thank you very much. Dr. Cameron Muir, Executive Vice President, Quality and Access, Capital Caring, the Innovations Group.
Good afternoon to the Institute of Medicine's Committee on Transforming Care at the End of Life. It is an honor to be able to submit comments today. I'm Dr. Cameron Muir, and I'm presenting today on behalf of Capital Caring as well as the Innovations Group. Capital Caring is one of the nation's premier hospice and palliative care providers. We are a nonprofit, community-based, mission and value-driven organization with over 650 employees, 950 trained volunteers in Greater Washington, and care for over 1,200 patients daily through an interdisciplinary care team to provide holistic support to patients, caregivers, and their loved ones in 6 distinct programs promoting hospice and coordinated advanced illness care. I'm also here on behalf of the Innovations Group, a new collaborative of 20 nonprofit, community-based healthcare innovators that focuses on operational innovations in care delivery and on influencing the current debate around emerging payment and care delivery models, especially in hospice and advanced illness. Our mission is to strengthen the current hospice benefit, to preserve the movement's original intent, and to actively participate in building a more compassionate, efficient, and responsive healthcare system for Americans living with advanced illness, to strengthen the care continuum and reinforce the care bridge for the seriously ill into hospice. The context and trends that this committee identified in 1997 still hold true today. As noted in 1997, the process of dying has changed in the last 100 years. We argue that it will continue to change. The process of dying has changed in the last 30 years since the Medicare hospice benefit was instituted, and even again in the 15 years since this committee's report. But today, the first baby boomers have now hit 65, and the absolute number of dying patients will be substantially higher. Pressures to control costs have also escalated far beyond what they were in 1997. We cannot afford to wait any longer. We must create nimble and effective systems of care that reflect this reality. Hospice is uniquely qualified to inform care delivery for seriously ill patients as one of the longest-standing Medicare care coordination benefits, administering comprehensive set of services via an interdisciplinary team for person-centered care. While many of the recommendations in the 1997 report still require attention, including continuing public discussion, increased use of palliative care in different settings, and focus on professional education, we would contend that this committee should pay particular attention to healthcare delivery and payment mechanisms to strengthen hospice as well as formalize a standard set of advanced illness coordinated care services. Compared with 30 and 15 years ago, people get sick and die differently. Americans are living longer, more active lives with multiple chronic conditions that impose significant physical, emotional, spiritual, and financial burdens. Our healthcare systems are configured to manage these acute episodes of illness and injury and are ill-equipped to care for the huge impending growth in the number of aging boomers. The 3 decades-old hospice benefit has been a tremendous success but needs to be upgraded to the 21st century post-reform reality. To reinvest in the current hospice benefit, we must address 2 challenges. First, the statutory requirement of patients who elect hospice to forego concurrent, potentially life-prolonging therapies creates a forced and untenable choice, leading to very late admissions to hospice. While hospice use is increasing, people tend to only choose hospice after exhausting all other options, often doing more harm than good, while a higher quality and more prolonged life could have been pursued in hospice at lower costs. This reflects a fundamental misunderstanding. Hospice is not about a place to die. Hospice is about maximizing life. We must continue to educate patients across the continuum and ensure that hospice is a part of the status quo in the delivery earlier when it can be most beneficial. Second, the practice of medicine has evolved since the eligibility criteria of hospice were established, requiring a physician to certify that a Medicare patient has a prognosis of 6 months or less. Due to medical, financial, and social advances in the past 15 and 30 years, life expectancy is not readily predictable for a person diagnosed with the common life-limiting serious conditions such as cancer, heart failure, or Alzheimer's disease. With the same diagnosis, one person may live 3 months and another person may live a year and 3 months or longer. This is also where we begin to see an emerging dichotomy in the hospice debate. On one hand, there is wide acknowledgement that the vast majority of people are accessing hospice services too late. Nationally, hospice has a 6-month benefit, longer if recertified, with a median length of stay around 20 days and 35% of patients living only 7 days or less. We believe that this is a travesty. On the other hand, there is another cohort of hospice patients that live beyond 180 days, 12% of the total patients. While intended to reduce fraud and abuse, the highly punitive payment oversight process of hospice targeting those 12% of users has backfired, leading to more costly and poorer quality of care by maintaining the crisis, hospitalization, discharge, crisis, rehospitalization cycle. It too often impels hospice programs to discharge long length of stay patients, commonly without anyone to take over that care, creating a moral crisis for hospice professionals and no recourse for patients but to return to the hospital in a too often more rapid decline. This is a moral failure for these patients, whether they're in hospice or in broader care management and palliative programs, and this deserves supportive care and honor and dignity. Addressing this entire regulatory and payment mechanisms must be assessed in a comprehensive way, looking at the entire continuum for patients with advanced illness, not just silo by silo, benefit by benefit, to ensure that we're able to make a real impact. Addressing this entire continuum means simultaneously addressing dysfunctional care for those pre-hospice living with advanced illness. Each person with an advanced illness differs in terms of their social, functional, medical, and emotional context. The skills, expertise, and experience of hospice professionals and an interdisciplinary coordinated care model of hospice are well adapted for this range of circumstances. And so hospice provides the foundational elements necessary to build out what many have been calling advanced illness coordinated care. While appropriate utilization of hospice must be addressed, policymakers must simultaneously attend to their constituents with advanced illness. There are tens of millions of lives at stake, and we must create a seamless transition to hospice. Thank you again to the Institute of Medicine and this committee for taking another look at this issue. This committee is an extraordinary group of people with the expertise and backgrounds to make a real impact. We know that there are many stakeholders capable of assisting you in this process, but we'd be very happy to provide additional input as the committee's work moves forward. We must all work together to make a difference. Thank you.
Thank you. Now, we've had one other individual who did not sign up in advance request to speak, and I think given our time, that would be fine. Catherine Weber from Compassion and Choices. If there are other individuals who seek to speak and can constrain it to the 3 minutes, we're willing to entertain that. Adrian, could you please raise your hand in case there's anybody else? Please see Adrian if there's anybody else. But again, we really need you to keep it down to 3 minutes since there wasn't an advance request. And with that, Catherine, please proceed.
Okay, thank you. I'm Catherine Weber. I'm a resident of Annapolis, Maryland, a retired clinical social worker after about 40-some years. I want to speak from two perspectives. One is the caregiver of my husband, who died 6.5 years ago of lymphoma. He was treated at NIH, received wonderful care. When he did not go into remission, we were basically sent back to the community with no discussion about what was going to happen next. All I can say is that that time was a frantic time. Whatever I knew as a clinical social worker, my husband as a university professor who taught cancer, just went out the window. And we ended up in a crisis, 1 week in hospice, and my husband suffering and conscious until the very end. It was a very difficult time. 2 years ago and a little more, I was diagnosed with metastatic breast cancer in the bone. I'm obviously doing well. I walked all the way from Foggy Bottom Metro Station and enjoyed it. However, I know that sooner rather than later, I will be dying of metastatic breast cancer. And I wish that I could say that I feel confident about what will happen at the end of my life in terms of treatment. I obviously have time to plan, to talk, to find out about palliative care in my community, which has just been introduced, and so on and so forth. But the Dalai Lama has said that if you have fear of some pain or suffering, and there's something you can do about it, there's no need to be afraid. And so what I'm doing at this point is trying to dedicate my time to a legislative initiative in Maryland to bring physician aid in dying to the citizens of Maryland. Rosalind Kipping has already talked about this issue. We think that this is one important piece of the formula that needs to be available to people who are at the end of their lives. Thank you.
Thank you very much. And do we have other requests? Thank you. Thank you. Maureen Rigney, Lung Cancer Alliance.
Hi, thank you for allowing me to speak. I just wanted to give a little bit of a patient advocacy organization perspective. I'm Maureen Rigney. I'm a licensed clinical social worker with Lung Cancer Alliance. We're a national nonprofit based here in Washington, D.C., and our mission is to end injustice and save lives through an alliance of advocacy, support, and education. And I just, with a survival, 5-year survival rate of around 16%. A lot of lung cancer involves end-of-life care. And while I think that, too many people think that a stage 4 diagnosis of lung cancer is an automatic death sentence, which it isn't, far too often people are treated at the end of life when they shouldn't be. And I love the concept of a death diagnosis because a lot of these conversations aren't happening. I have the privilege of answering our toll-free information line, talk to people from all over the country every day, and a week doesn't go by, sometimes several times a week, that I don't talk with a caregiver or a loved one who's elderly, bedridden, parent usually, is dying, and then they're looking for another opinion. They want to go someplace else. Sometimes the person is in hospice. And I'm not saying that conversation hasn't happened, but it hasn't happened in a way that they can understand. So here I am, a stranger on a phone in Washington, D.C., talking with them about the fact that their parent is actually dying, and it's time to make that transition to saying the things that you need to say and preparing for the end of life, which can be very difficult. And of course, very, very much encourage people to start hospice as early as possible. But in that, and you all know so much more about end-of-life care than I do, but there seems to be a gap in service. And certainly if people are entering hospice earlier, their psychosocial needs are different and they're going to need more support, especially perhaps peer-to-peer support, group support, and that type of thing. So I just wanted to make a case for that. So thank you very much for allowing me to speak.
Thank you very much. Gail Hunt, National Alliance for Caregiving.
Hi. Besides being the head of the National Alliance for Caregiving, I'm also on the board of PCORI, the Patient-Centered Outcomes Research Institute. And in both of our organizations, we've come up with the issue of family caregivers, which I noticed was only mentioned in passing a couple of times this afternoon. But the role of the family caregiver is not just to be the person who helps to make the decisions and then implement them. The family caregiver has needs as well. So I would suggest that when you're talking and thinking about how you might want to redesign the system, please keep in mind the needs of the family caregiver, as well as the family caregiver as the essential cog in the end-of-life preparation and follow-through. The family caregiver may not necessarily have all of the skills or be able to do this without some kind of respite and support. So I think that it's really important that we consider the family caregiver's role. And the only other thing I just say, and this is because wearing my PCORI hat, please don't be too afraid of the death panel issue, because that's something that we talk about a lot at PCORI, and I think it has kind of made us very skittish about some of the issues that we might take on. But you guys, I think you should go for it. Thank you.
Thank you very much. One of the reasons we're taking on this issue is because this issue is important, it's timely, and it's been demagogued. And it's time to address it head on. Joan Pankey, Palliative Care NP, please.
I'm so glad to have an opportunity to actually speak. I am a palliative care nurse practitioner, and I've been working in the field for close to 20 years in various capacities of clinical practice, education, and research. But I really wanted to talk to you today as a family caregiver. So apparently the family caregivers are getting a little bit of more of a say. I spent the last year, I'm actually one of the statistics, leaving the workforce and caring for not one but two parents with serious illness. And I do hope that the committee pays specific attention to some of the critical gaps in care, and that is in caregiving, paid caregiving. We have wonderful resources. I believe my family experienced the absolute best that palliative care has to offer and that hospice has to offer. My father was bedbound for 4.5 years. The last time, he died 2 months ago, the last time he was in a hospital was 4.5 years ago. The last time he was in a physician's office was 4.5 years ago. He had exquisite symptom management. He died where he wanted to die, at home. But the impact on family caregiving, financially, having to leave the workforce, we don't have adequate resources to be caring for families to do the right thing. So something needs to be really looked at in focusing efforts on ensuring that people's wishes are honored, that they live the way they want to live and die where they want to die, but without going broke. So I really encourage you to think about this particular issue. Thank you.
Thank you. William Benson, Health Benefits ABCs.
Thank you. I'm here today not for my organization, Health Benefits ABCs. I'm here as president of the International Association for Indigenous Aging, or IA Squared, and today I'm speaking for our executive director, Mr. Dave Baldridge. Dave is an enrolled member of the Cherokee Nation, and he's the former director of the National Indian Council on Aging. He lives in Albuquerque, so he couldn't be here himself today. The Centers for Disease Control and Prevention's Healthy Aging program recently published a critical issue brief addressing end-of-life care in Indian country. It was written by Mr. Baldridge with assistance from myself and from Nancy Aldrich of our staff. This report examines 4 American Indian end-of-life programs that are demonstrating extraordinary success, measured in part by rates of patient and family compliance with advanced directives, DNR orders, and patient satisfaction surveys. Surprisingly, this effort revealed strong evidence that long-standing perceptions of cultural and racial barriers are not accurate. Existing paradigms of culturally appropriate end-of-life care may no longer apply. In these 4 programs, provider empathy emerges as perhaps the foremost critical factor in the acceptability of end-of-life discussions. Both researchers and public perception have long assumed that some minority populations are adverse to discussions about end-of-life issues, and then in particular, traditional Indian beliefs preclude these discussions. Yet one Indian Health Services medical and social work team working in Fort Defiance, Arizona over 10 years in the heart of the Navajo Reservation, one of the most traditional of Indian tribes, produced a 90% success rate with durable medical powers of attorney and advanced directives, far above national rates. As a result, the program director, a non-native, was invited to become an honorary member of the Navajo Medicine Man's Association, a previously unimaginable honor. At the University of New Mexico Hospital, similar rates of measurable success are occurring in a patient population that is 40% Hispanic, 40% white, and 10% American Indian. In urban Albuquerque, Native patients may come from any of dozens of tribes. Following consultation with their EOL program, Native patients' preferences for putting an advance directive order in place increased from 22% to 62%, and family end-of-life meetings increased by an even greater rate from 30% to 76%. The program is having a significant effect. In this hospital, which is New Mexico's only level 1 trauma center, the small end-of-life staff does not benefit from the long-time personal acquaintances and deeply embedded cultural relationships as those at Fort Defiance. As the University of New Mexico program director said to us, most of our patients come to us already in crisis, so we try to create an immediate plan of care which evolves from their issues and those of their families. She said, the secret is to come in with no preconceived assumptions and to let the patients and their families take the lead. Most of our patients are in such emotional pain that they appreciate anyone who will listen and who cares about them. In short, this is her words, empathy trumps culture. Similar results are occurring at the Zuni Pueblo in New Mexico and at the Cherokee Nation in Oklahoma. Both are featured in the paper we wrote. Empathy emerges as perhaps the single most important aspect of end-of-life care for American Indians. We suspect this will be the case for most Americans who face end-of-life issues. Empathy, Mr. Baldrige notes, is not the same as cultural sensitivity. While cultural practices can be learned, empathy and the ability to emotionally relate to another's experience is a personal quality that perhaps cannot be taught, at least readily. Thank you.
Thank you very much. Now, are there any other individuals who would like to request to testify? We've done very good on time. If I can, let me just mention several things that I heard, and I'll see if my colleagues want to mention anything else, that I would ask that if you want to submit anything else for the record in connection with this, to please do so to the extent that you haven't already. For example, as has been mentioned, there are cultural challenges here, multidimensional cultural challenges. There are language issues. Words matter. To the extent that people have thoughts, suggestions for our consideration about how best to deal with some of these cultural barriers, dealing with patients, dealing with physicians, dealing with other, key stakeholders, and some alternative terminology that might be able to be used, then we would be interested. Secondly, the concept of death diagnosis has been mentioned. To the extent that, additional information can be provided about, when and how and who is involved in that process, I think that could be helpful. Barriers, several things have been mentioned about existing laws and potential, how they might represent barriers in certain regards. To what extent might there be additional examples of that have not been provided? And then last but not least, and then I'll ask my colleagues if they have anything else that they just want to mention for providing for the record rather than asking questions now. Stories, very, very important. Stories of positive experiences, negative experiences, things to try to bring this very, very important issue alive, because it's much better to be able to communicate that way to the extent that you can, use stories. And let me see, is anybody else that wants to raise an issue based upon what you've heard? Or okay, does that mean we get a longer break? I think we've been rewarded with a longer break. So if we can, I know what time it says we're supposed to come back, but what time are our speakers going to be here? Yes, Adrian? At 3? All right, let's return at 3 o'clock. Thank you very much. And we look hopeful to see some of you here at 3. Thank you.